All right. Hi, everyone. Welcome to our presentation today. Today's topic is pretty sensitive, so I encourage anyone who needs to take a step outside to please do so, because today we're going to be talking about suicide awareness and resources. Today, our presenters are Jihoon, myself, Ashley, Eddie, Josh, and Brittany. We will be discussing or starting with our discussion prompt with two questions. Where in the Bible have you seen suicidal ideation or death by suicide? And when and where in the physical therapy department is the topic of suicide being discussed or educated on? And what are the resources available for individuals facing suicidal ideation and or death by suicide? And we'll take a moment here to pause so that you guys can discuss. And now I'll be passing it over to Eddie to talk about the definitions.
Thank you, Ashley. So we're going to talk about the definitions that are relevant in this topic. So for suicide, this is defined as death caused by self-directed injuries, behavior with intent to die as a result of the behavior. Suicide attempts are unsuccessful attempts to endanger oneself and to harm oneself. Suicidal ideation refers to thinking, considering, or planning the idea of suicide. So some statistics that were recorded from the CDC web. It was collected on in 2022 and was finalized in June of 2024. And the results showed that suicide was the 11th leading cause of death, which accounts for 49,400 lives. Men were 4 times more likely than women to commit suicide. And there are three different ways that people can commit suicide. The leading cause was firearms, second was suffocation, and third was poison. So the prevalence of suicide is high among two age groups, 18 to 25, and specifically those who are interracial, and also in the elderly group, ranging from 75 to 85-year-olds. Suicide is also prevalent in American Indians and Alaskan Natives. And now we will hand it off to Brittany.
Thank you, Eddie, for giving us some statistics. So next, we're going to be talking about some warning signs of suicide. So whether it be your patient, your colleague, or your friends, here's kind of some things to look out for. If you find a person frequently saying, I'd rather not be here, or I don't want to be here anymore, that can definitely be a sign of suicide, as well as saying things such as, like, I feel like a burden to those around me. So kind of watch out for phrases like that, as well as a person showing signs of guilt and shame. People who can also show signs of suicide are withdrawn from their family or friends. They can also say unusual goodbyes. They also may display mental health issues such as extreme mood swings. They may be eating or sleeping more, and they may also partake in risky behaviors. Some potential risk factors associated with suicide. There's a lot here, so I'm just going to be touching on a few. So for those who have had previous suicide attempts, their risk factor for suicide does increase. And if they've had a history of depression or any sort of mental illness, if they have had any recent financial or chronic job instability, and for those that have had adverse child experience, can also have increased risk of suicide, as well as those limited who have limited access to healthcare. Thank you, Josh.
Thank you, Brittany. So, coming with physical therapy and suicide prevalence. So, we as physical therapists may encounter patients with suicide thoughts, right? In any setting, acute care, outpatient, or specialty settings. PTs can observe the signs and can encourage patients to get help and provide resources. Something that we see a lot as therapists is patients with chronic pain, chronic low back pain, anything chronic really. And people who have these chronic pains, it was interesting to find that 20% of them had suicidal thoughts, probably because of the pain that they're experiencing. And then top suicide rates are among elderly individuals. So since PTs work with the geriatric population, a lot of older patients, noticing the risk of suicide in these patients are important. Lastly, neurological and post-traumatic rehab. Patients who may have a stroke, traumatic brain injury, may have a, a different approach in life after that. So we have to know um, what are their thoughts or experiences with suicide.
Okay, and we now have the impact on patients of physical in the realm of physical therapy. So this is an example patient who went through this experience. So it says here the pain got worse and that had an effect on my mental health to the point where I attempted suicide a month ago. What really used to save me was my physiotherapy. I used to go twice a week. It made me feel better, but without my physio, I'm uncomfortable all the time, not able to sleep. And when I saw my situation, I said to myself, this is how it's going to be until the end of my days. Without COVID, I may not have attempted suicide because without COVID, I would still have physiotherapy. And then continuing on, as you saw in that quote, it really shows the impact of physical therapy and its association with pain, especially chronic pain, and how it can really mess up the person's mind to even think of committing suicide. Um, and one thing that really stands out from this slide is that there are a lot of patients that have, for whatever reason, reluctance to get therapy for professional help. I think there's some kind of stigma attached to that. And not as many people are reluctant in seeing help for pain. And since we just found out that pain is highly associated with suicidal ideation, our profession is a bridge for uh, bridging profession between physical and mental health services. And it's worth noting that there are a lot of populations that are hard to reach, populations that are have that high stigma um, to participate in physical therapy, and this can be populations that um, are like, for example, men from rural communities. They are typically very to themselves, and so it's a example of how physical therapy can reach out populations that would be hard to reach out in other settings. So, well, one of the ways we can really ask our questions in our evaluations is, for example, does the pain get you down? In what way? And this will help us explore potential emotional factors of the patient. And one of the ways how they could respond if they have a suicidal ideation is, I'm at a dark place, I've lost hope, and I see no way out. And it's really important that we are well educated in this matter because only about a third of DPT programs include suicide risk assessment. And also, PTs are the only, I wouldn't say only, but one of the few professions where you're able to build rapport and a trusting relationship with the patient over an extended period of time. So it is a lot easier for us to get the patient to open up than, let's say, you were to have like a one-time session with the patient. I think it takes time for people to open up, and it also then that is exactly why you need to build rapport with your patient so then they could open up in their own voluntary will. So those some of the things that we could do is active listening, be friendly and kind. We can empower the person, but don't also oversell your abilities. And be respectful. And that means you're establishing your boundaries, respecting their boundaries, because in the end, it's their autonomy to choose whatever they want to do. And also don't interrogate, but build rapport so then they can open up and reduce their physical pain and be informed in ways where we can allow them to seek additional help that is outside of a scope of practice. And then now I'm going to hand it over to Ashley.
Thank you, Jihoon, for that. Next, we're going to move on to the case study to practice what we've learned. You have a patient coming to you named John D, whose age is 32 and is male. His occupation is an office worker, and he's coming to you with chronic low back pain due to a lumbar disc herniation. He does have a history of anxiety and depression managed by medications. He lives alone and lost his younger brother to suicide 6 weeks ago. I'm going to pass it to Josh to continue this case study.
Thank you, Ashley. So at the initial evaluation, John D presents to your outpatient PT clinic for treatment of chronic low back pain. He reports a recent increase in pain intensity, stating that his usual coping mechanisms, including stretching and light exercises, are no longer efficient. During the subjective portion of the evaluation, we notice that John appears withdrawn, speaks in a monotone voice, and has difficulty maintaining contact. When asked about his pain, he vaguely responds that it doesn't really matter much anymore. As you continue your assessment, he discloses that his younger brother died by suicide 6 weeks ago and that he has been struggling to find a reason to keep going. When probed further, John expresses feelings of hopelessness, saying, "Sometimes I think it would just be easier if I weren't here." So, with this case study, there are several questions that I want to state. As a PT student, how would you respond to John's statements in real time? How does this scenario challenge traditional views of the PT's role in patient care? What legal and ethical considerations should be taken in account when addressing a patient with suicidal thoughts? How would you modify John's physical therapy treatment plan given his distress? What interprofessional referrals would be appropriate in this case? Alrighty, so after those questions, this is a resource of how you can help, right? I like to think of 5-step action, right? So first you want to do is ask, are you thinking about killing yourself? Step 2, be there. Listen without judgment and acknowledge their feelings. Then you want to help keep them safe in step 3. Reduce their access to lethal items or places. Then we can help connect. Call or text 988 Suicide and Crisis Lifeline, which we will talk about a little later. And we can follow up with the patient. That's not it, right? You want to stay in touch, see how they're doing, see if they don't actually go and do what they wanted to do, which is kill themselves. All right. So resources, this is very important. We talk to our patients like, oh, yeah, don't do that, but how can we give them a resource, right? So dial 988 or visit this website for support, the Suicide and Crisis Lifeline. It's good because it's available 24 hours, 7 days a week, right? And also Canada, there's Talks Suicide Canada, which is this number. And we have people who are from Canada and United States, so it's really important to have that. And also LGBTQ support. The Trevor Project, which is very important also. Alrighty, thank you for listening.
So here are the references that we used for our research topic. If you guys have any questions about suicide or any statistics, make sure to talk to Dr. Young about it, as some statistic sites may vary in their stats. Thank you for bearing with us through this tough topic, and we hope that you guys learned some new information, that you were able to have resources that you needed, and hopefully in the future you will feel more comfortable talking about suicide, being aware about it, and knowing how to help your patients in the future. Thank you again, and hope you guys have a great day. Thank you for listening.